much for looking forward to session. And we have, this is the fifth session of after President Dr. Rajendran has taken over. And we are very happy that we have the experts here. Now I request Dr. Rajendran sir, President IAP Tamil Nadu State Chapter, to deliver his presidential address.
Thank you, Dr. Narmada, and it's my great pleasure and a privilege to be here, and respected President-elect Dr. Somasundram, President 2024 Dr. Balshankar, and Dynamic Secretary Dr. Narmada, and Academic Coordinator Dr. Tirumurugan, and Treasurer Dr. Rajkumar, and Central as well as State EB members. And on behalf of IAPT, I welcome Dr. Kasi sir. He's a well-known personality all over India, more than that in the international also. On behalf of IAPT, I welcome sir, and really we are honored that you are here. And definitely it will be one of the best program today for our IAP Tamil Nadu. And I welcome Dr. Rakshana Das, and she's also a well-known personality. He's more interested in emergency as well as immunization also. On behalf of IAPT, I welcome Dr. Rakshana Das, and I think that today's program convener Dr. Nandini and as well as Dr. Jalil sir, they will definitely coordinate this program very well. And once again, on behalf of IAPT, I welcome one and all. Thank you very much. Thank you.
Thank you, Dr. Rajendran sir. We have a spate of academic program, and the best part of it is our Dr. Singaravelu sir, the scientific advisor, has very well crafted all the program and also made a point to attend all the sessions, though he's traveling extensively for this presidential campaign. Dr. Singaravelu sir, for your felicitations, please.
Thank you, Dr. Narmada, the most dynamic president who has brought a lot of activity this year, Dr. Rajendran, and past president, and our immediate President-elect Somasundram, our dynamic secretary Narmada, and academic coordinator Thiru, and Raj, all others who will join. And today's program, the ICE program, is going very well under the coordinatorship of both Dr. Jalil, Dr. Nandini Madam. And top of that, the Dean of Vaccinology, none other than Professor Kasi sir, is with us. It is a great honor for us today, sir. Thanks, sir, for accepting our invitation. Added flavor to that, Azaria Madam, a great academician and a great teacher who has also joined. So always our people are bringing very good academicians into this forum so that it will benefit all our postgraduates and practitioners. In our Zoom meeting limited, but in all our YouTube, many of have joined, and definitely it will be a very useful program and all will be benefited. And our process also joined. Thank you for giving me this opportunity. Wish you all the best to all. Thank you.
Thank you so much, sir, for your nice words, and thanks for joining in spite of your hectic schedule. I request our IAP past State President, Dr. Balshankar sir, to give his felicitations.
Good evening, Dr. Rajendran, Dr. Narmada, Dr. Thiru. This is a really nice evening, continuous CMEs. So much is being bombarded to our old heads, actually. The next CME on vaccines. It is very, very nice to have the key person who is the leading light in vaccinology in India, Dr. S.G. Kasi, in this forum. Thank you very much, sir, for accepting our request and coming. And I also welcome Dr. Rashna, who is also an expert in vaccinology. I hope this evening will be a very, very useful evening, and we'll all be learning a lot of points from Dr. Kasi and Dr. Rashna. Thank you very much for the opportunity. And this IAP, this vaccinology ICE module is one of the best one we have come across in the history of Tamil Nadu IAP. Thank you, Dr. Rajendran and team, for that. Thank you very much.
Thank you so much for your kind words, Dr. Balshankar sir. A perfectly prepared flyer, the perfectly collated speakers. It's all the compliments goes to our academic coordinator of IAP Tamil Nadu State Chapter, Dr. Tirumurugan sir. So please give your felicitations.
Thank you, Dr. Narmada. I think we are really proud to have this program, ICE program, every other month. Having said that, I think we needed more than that, so we have gone more than our quota, and then and it's really very nice to have Dr. S.T. Kasi sir, who has been our teacher. I think both our teacher in the vaccinology program, and who is absolute star of vaccinology in the country. And with Dr. Hasna Hazarika ma'am, Rasna Hazarika ma'am, I think we really will enjoy the show. And when I always say, when Dr. Kasi sir speaks, everything seems so simple, and when he stops speaking, everything becomes so complicated. So I'm sure it won't be the case anymore. So thank you very much, sir. Thank you for joining us. Thanks, ma'am, Doctor, for joining
Yes.
us.
Thank you so much, Dr. Tinamurigan. We acknowledge the
Thank you.
presence of our Vice President, Dr. Gopal Subramaniam. Sir, do you want to just add a few words?
Thank you, Rajendran sir, Narmada, Thiru, and office bearers. It is a wonderful evening. Dr. as past President Dr. Bore said, and I would like to thank Kasi sir and Rashna madam for this opportunity to us for the learning, and wish the program a grand success.
Thank you.
Thank you.
Well, thank you so much. The immunization dialogue has been very well coordinated by our experts, Dr. Nandini Kumaran Madam and Dr. Jalil sir, the convener of the same. So now I would like to hand over the platform to them for further proceedings.
Nandana, Narmada, can I?
Yes, sir. Nandini Madam,
Yes, sir. Yes,
US,
sir.
I think. So please proceed.
Good evening, all. The most respected President, Dr. K. Rajendran, our past President Balasankar sir, and the President-elect in absentia, Somasundaram, and Honorary Secretary Narmata, and Vice President Gopal Subramaniam, and Academic Coordinator Thirumurugan Sirin, and the viewers, and most important, the speakers, stalwart speakers. I thank from my heart. I approached Srinivas sir 2 months back for the same program. She was very busy. So on behalf of IAP Tamil Nadu State Branch, we extend warm welcome you, sir, for this wonderful 4th episode of ICE, that is Immunization Colloquium by Experts. And also I welcome Rasna Das Hazarika Madam for this platform. I thank the IAP TNSC for considering this in the action plan module also. Without much delay, I have a privilege of introducing Professor Dr. Srinivas G. Kasi. He requires no introduction. Almost perennially he is speaking to us. He is a consultant pediatrician in Bangalore, past president of IAP Bangalore, past vice president of IAP National Respiratory Chapter. In the ACVIP, was a member between 2011 and 2013, was a convener, advisor between 2022 and 21, was an editor IAP question and answer in vaccinology, and he was a sole author for the IAP Purple book, which we are all referring on the table. He has contributed chapters on vaccinology in various IAP textbooks. He has delivered 7 oration and 4 endowment lectures. So with this, I hand over the mic to Professor Srinivas G. Kasi sir. We have 3 topics: hepatitis A, typhoid, and meningococcal vaccines. So it starts with Professor sir, then followed by Rasna madam, then again sir will take the 3rd topic, and question and answers can be answered at the end of the session. Over to Professor Srinivas Kasi sir.
Thank you, Dr. Jalil. Thank you for elevating me to the post of professor. I'm actually not a professor. I have never been attached to any teaching institution. That's it. So I'll just share my slide. At the outset, my sincere thanks to IAP Tamil Nadu State Branch and also the Scientific Committee of the ICE Symposium for inviting me to this very prestigious and successful program. I'm also thrilled that I'm sharing the diet with Dr. Rashna Das. I think her knowledge on meningococcal vaccines is probably unparalleled in our country. So I'll be very eagerly awaiting for her talk as well. I'll just share my slides. I will first deal with hepatitis A vaccines. I think my slides are visible.
Make it full show, sir.
Yeah, it is full show now.
No, sir, not yet.
No, sir,
No.
it's not full show.
No, it's not on PowerPoint mode. So
Wait. I'll just stop sharing and I'll share again.
Yeah.
Now,
No, sir.
No, sir.
why is that? Wait, just give me a minute. I think I had already put it up. 1 second. One second. I'll just. Full screen.
Yes, sir.
Thank you. So, 20 minutes. Let me discuss what is possible about hepatitis A vaccines. Now, this is the hepatitis A virus. This is how it looks under the electron microscope. A very simple virus, a single RNA strand, no envelope. Because there is no envelope, it is highly resistant to common detergents. There are 6 genotypes, 3 which infect humans, 3 which infect primates. Human infections are predominantly caused by genotype 1. So for all practical purposes, is the only genotype which causes infections in humans. We all know that it has a fecal oral route of transmission. It is basically a hepatotrophic virus which resides in the liver. Contaminated food and water are the main source of infection. We must also remember this virus is very resistant to harsh environments. And it is not activated by most of the common detergents. So basically, bleach is the only thing which can kill the hepatitis A virus. That's why it has this tendency to transmit and cause huge outbreaks and epidemics, especially where we do not have adequate sanitation measures. It has an incubation period of 50 to 40 days with an average incubation period of 2 weeks. This has implications because post-exposure prophylaxis will be highly successful when we have a long incubation period illness. Another peculiar thing about, like many other viral infections, the clinical manifestations are age dependent. Now, generally in children below 5 years, 80 to 95% are asymptomatic. In fact, if you go below 2 years, almost all are asymptomatic. Adults, only about 10 to 25% are asymptomatic. Conversely, 75 to 90% is symptomatic in adults. Complete recovery is generally the rule in children, whereas about 2 to 3% may have some issues in adults in the form of either prolonged jaundice, recurrent jaundice, etc. The case fatality rate is less than 0.1% below 15 years, 0.3% in 15 to 39. Above 40 years, the CFR is about 2.1%. But what is important that even in adults, it is estimated that one episode of hepatitis A gives rise to an average loss of 30 working days. And that's a very, very significant amount. Okay. We always believe that hepatitis A is a very benign illness. Everyone is going to get infected. Everyone is going to become seropositive and nothing is going to happen. But this was a study done in Pune, published way back in 1999, which showed that. Hello. Yes.
I request all to kindly mute yourself.
Thank you. So, this studied 36 cases of fulminant hepatic failure. 34% were due exclusively to hepatitis A, in 6% co-infection with hepatitis B, and in 11% co-infection with hepatitis B. So, more than half the cases of fulminant hepatic failure had some relationship to hepatitis A virus. We talk about endemicity of the virus. Let's understand what is this endemicity. Look at the red areas. India is in that red areas. We are in the high endemicity zone. That is, more than 90% of the population becomes seropositive by the age of 10 years. The second is intermediate or medium endemicity, where greater than 50% become positive by 15 years, but by 10 years, less than 90% are positive. So a little lower force of transmission. Then we come across the low incidence, where again the seropositivity is more than 50% by 30 years, but less than 15% by 15 years. And finally, we come to the very low endemicity, where anti-HIV positive is less than 50% by 30 years. See, this has implications because when you have very high endemicity, you are hardly going to see any clinical illness because every child becomes immune and the immunity lasts almost lifelong. Whereas as you go lower down in the grade of endemicity, you start seeing very high number of cases, especially in the intermediate endemicity zone. Now, what we must remember is that many countries are transitioning from high endemicity to intermediate endemicity. Now, I have some questions which I can put up to the audience. Just type the answers, 10 seconds for each question. In India, shifting endemicity is occurring because of improved socio-economic conditions, improved sanitation, hygiene, and drinking water, or it's because of vaccination coverage. Which is the right choice? Can we have some responses? We'll just take 5 seconds gap and then I will give the answer. Are there any responses? Yes, I am getting
Yeah.
all 3, 2, fine. Let's go to the answer. Basically, the correct answer is improved sanitation, hygiene, and drinking. Of course, this is linked to economic situation, but this is the primary factor which is giving rise to shifting endemicity. Now, what is shifting endemicity? Now, India is shifting towards intermediate from high due to improvements in hygiene and sanitation. So 30% to 40% of adolescents and adults, especially in urban areas in the middle, upper middle and high socioeconomic class, are seronegative. That is, they are getting infected later in life where hepatitis A carries a higher disease burden. Pregnant women was found in a study in Delhi, almost 20 to 25% was seronegative. So the infants are not having any passive protection. Outbreaks never occur in high endemicity. Since we are having outbreaks, it is an indication that we are shifting to intermediate endemicity. And there's an increasing contribution to fulminant hepatic failure. So if you look at the shift in seroprevalence, it is occurring across all age groups. And in this 20-year gap, 1 to 5 years, 70 to 90% has come to 26%. 6 to 10 years from almost total has come down to about half, 50%. And if we take the entire age group of 1 to 10 years from 96 to 98%, it has come down to 37.5. This is described not just in urban and even in rural areas as well and across the country. This has implications for use of the vaccine. We have two types of hepatitis A vaccines, the formaldehyde inactivated and the live attenuated. Formaldehyde inactivated, we have again three types, the Havrix, which is the HM175 strain, Evaxim, which is the GBM strain, and then we have a couple of brands which belong to TZ84 strain, which have been introduced in the not too recent past in our country. Live attenuated, we have one called Biovac A, which is made from the H2 strain. There is one more live attenuated strain called LA1, a Chinese vaccine, which is still not licensed in our country. There are some differences between the inactivated and the live. Just have a brief bird's eye view of this. Killed vaccine, I'm taking the HM175, that is Havric as the prototype. 2 doses, 1 dose. Now, the seroconversion, 100% seroconvert within 19 days following vaccinations, whereas this 100% seroconversion takes 3 to 4 weeks to live attenuated. So this has relevance when you're deciding which vaccine to give for post-exposure prophylaxis. Antibody titers are always higher with killed vaccine, not only for hepatitis A, with many other vaccines. Long-term protection, we have more robust data with the killed vaccine. We have data from live attenuated vaccine, but only from one center in USA. In China, killed vaccine can be used in the immunocompromised, live cannot be used. Rule for IM subcutaneous, and minimum age is 1 year for both. So this in brief are the differences between the killed vaccine and the inactivated vaccine. I'll first deal with the inactivated vaccines. It's a liquid formation stored at 2 to 8 degrees. It should not be frozen. All hepatitis vaccines are licensed for use in children above 1 year. We must remember that hepatitis A has a very well-defined correlate of protection. It's an absolute correlate of protection, and that correlate is 20 MIU per ml in the blood. Recently, the inactivated vaccines derived from He-Liv, which is a TZ84 strain, has been introduced, marketed by BE and Abbott. Havrix, Avaxim, and He-Liv are all WHO pre-qualified. These are all formalin inactivated and adjuvant with aluminum hydroxide. Inactivated vaccines are highly immunogenic. With one dose, almost every vaccinated individual above the age of 1 year becomes seropositive, 95% after the first dose and 99% after the second dose. Even when you start immunization at 12 months, regardless of maternal HIV status, the seroconversion is almost complete. The median predicted duration of protection has been estimated to be about 45 years. The vaccine is not so effective in the elderly, above 40. Here, 40 is above elderly. Immunocompromised, those with chronic liver disease, transplant recipients, and those with pre-existing maternal antibodies. That obviously means those less than 12 months of age. Inactivated vaccines gives rise to very rapid response. After one dose, seroprotective titers are observed in 79% by the 13th day, 86% by 15th day, 95% by 17th, and almost all by the 19th day. And this is much shorter than the incubation period of hepatitis A, implying that this vaccine is going to be very useful for post-exposure prophylaxis. The immune response lasts for a very long time. This was a study done with Havrix, where they followed up vaccinees for a period of 20 years, and as you can, in two schedules, 06 and 012. As you can see, at somewhere in the 11th year, there was a change in SA, so there was a drop. But as you can see, there's a initially first 2 years, 24 months, there's a very rapid drop, and it almost plateaus. And very high titers were found at 20 years, 312 and 317, compared to 20 that we need for protection. Based on these studies, it has been postulated that protection may last for as long as 47 years. And this, even in those who were seronegative, there was a very robust anamnestic reaction. So even in those who are seronegative and get re-exposed, they are going to be protected. Vaccine has been used in many countries. I will take USA as a prototype, which included, we started somewhere in 2006 and it dropped to almost negative levels. And as with many other vaccine hesitancy has risen. And again, there is a large number of hepatitis A cases reporting in various parts of the country. The decrease was almost 96% within a space of about 20 years. Israel is another country which has fantastic reports. What we should now emphasize is about the Argentina. See, Argentina decided to introduce only one dose in their NIP because 2 doses is very expensive. And surprisingly, one dose worked exceedingly well with a reduction of almost about 85% within 2 years. And this reduction was not only in the vaccinated group, it was across all the age group, indicating that this vaccine provides very robust herd immunity. Now, let's come to the next inactivated vaccine, that is He-Liv, that is TZ84 strain. The units are slightly different. Below 16 years, 250. Above 16 years, 500. It is produced in human diploid cells, adjuvanted. The dose is 2 dose, 0 and 6 months, above the age of 1 year. Now, this study has been compared with Havrix. This is a study from China. The bold line is TZ84, the dotted line is Havrix, and this has been followed up for almost 15 years. And as you can see, the seroconversion rates and the GMCs are definitely significantly higher with this Helium vaccine. And based on the antibody titers at 15 years, it has been predicted that at the end of 46 years, the titers are going to be 26.3 with 96.3 seroconversion rates, indicating again that even this vaccine has robust data regarding long-term protective efficacy. Let's come now to the the live attenuated. This is from the H2 strain, which was then passaged serially in the human diploid cells. It was first licensed for human use in 1992. It induces very robust cell-mediated immune response, licensed in China since 1992. Over 130 million have been vaccinated. This is freeze-dried, you have to reconstitute it and cannot be exposed to sunlight. Many field studies have been done, and this very large field study, which over 60,000 showed a vaccine efficacy of 100%. No case in the vaccinated group. It has proven to be useful even during outbreaks. We have robust data from our own country. This is a study done in Pune, which began in 2004 and has been followed up till 2019 for 15 years. And if you see the seroprotection rates, that is titers about 20, is present in 86% by the end of 15 years. And if you look at the GMTs are almost about 80, which is again 4 times that you necessary for seroprotection. And this is with a single dose. Vaccine has been used extensively in China, and as you can see, the overall reduction, and if you see the reduction in the very young, has been tremendous. In the very young, less than 15 years, within about 4 years of vaccination, hepatitis A disappeared. As vaccine coverage improved, it even disappeared in the higher aged population, indicating a very good herd immunity as well. So, disadvantages of live vaccines include all of the following, except live vaccine cannot be used in immunocompromised, may not be does not have much data regarding post-exposure prophylaxis, and it needs very stringent cold storage conditions. Can we have some 10 seconds response? Okay, I don't think we are having much of this. Anyway, the correct answer the wrong answer is needs stringent cold storage. It requires storage conditions like any other live attenuated vaccines. It cannot be used in immunocompromised, and its efficacy in post-exposure prophylaxis has not been very well studied. Now, a 2-year-old unimmunized child is brought to you as the elder child has developed jaundice hepatitis A 2 days ago. So what is the preferred action in this particular case? We have 3 options. Either reassure and say nothing is to be done, nothing will happen. You give vaccine or you give immunoglobulins. The correct answer is give the vaccine. Now, in case you give the vaccine, how effective will it be? Very efficacious, 75 to 85%. Now, if the child is less than 1 year, 10 months, vaccine is not vaccine, vaccine is not licensed. So what are the options? 10 months, hepatitis is going to be almost asymptomatic, do nothing. Vaccine, IgIM. I think vaccine is out. 1 and 2 both I think are equally weighted. We must remember that this illness is almost asymptomatic with total recovery in children less than 2 years. The theoretically correct answer is give intramuscular immunoglobulin, but I think even reassure and do nothing is an acceptable answer. So, what do you do for post-exposure prophylaxis? It is effective only if it is less than 2 weeks, less than 12 months, immunoglobulins, 12 to 40 years vaccines, above 41 years, because the response is not very good, you may have to consider give immunoglobulins. This is intramuscular, not intravenous. Anyone who is at high risk or immunosuppressed should receive immunoglobulins. If the exposure is more than 2 weeks, less than 12 months, nothing, more than 12 months, you can still consider hepatitis A, so that it may protect if there is no more infection. Now, a 15-year adolescent from a low middle class urban family, no past history of jaundice or vaccination, seeks your advice regarding hepatitis A vaccine because he is moving to a hostel. What should be your advice? Give vaccine, no vaccine, do titers and decide on need of vaccines. I think the IAP recommendation done long time back said do titers and decide the need on vaccine. But I think the correct answer should be give vaccine, because generally it is more cost effective to vaccinate than to do pre-vaccination serology and then give it. Of course, the pre-test probability that this child will be immune is high, but there is no harm. There are no adverse effects if you give the vaccine to a child who is already immune. Vaccine is much less expensive compared to the test, so probably worthwhile giving the vaccine. Now, a mother brings her 1-year child. This child was in a house 4 weeks ago, and in that house, a 5-year-old child develops jaundice today. So the exposure occurred 4 weeks ago. So what is the risk of hepatitis A for this child? Is it high, low, or no risk? I think I'm running short of time. I'll just give the answer. The risk is no risk because the infection period is 2 weeks before onset of symptoms to 2 weeks after onset of symptoms. And because this exposure occurred 4 weeks ago, definitely there is absolutely no risk, and this child does not require any prophylaxis. Thank you. And we can take questions at the end of the session as was suggested. Thank you. I'll stop sharing now.
Thank you, sir, for your wonderful presentation. We will take the question after the session, sir. Hello?
Yeah.
Okay. Now we move on to the second session. It is by Professor Dr. Rashna Das Hazarika. She is going to give lectures on meningococcal conjugate vaccine. It is my privilege to introduce Rashna Das Hazarika. He is a formerly professor of pediatrics, PA Sangma International Medical College, Meghalaya. He completed his UG/PG in Chandigarh. Her areas of interest: pediatric intensive care and emergency, pediatric infectious and respiratory disease, and pediatric rheumatology. He has got notable achievements. She has established the Department of Pediatrics in Shillong in January 2005. He had helped designing the MBBS syllabus for NEI-GRHMS in 2008. He has got a lot of publication, more than 50 papers. He had a wonderful research work, like conducted a number of multi-center projects under Indian Council of Medical Research and International Clinical Epidemiology Network. Her other administrative responsibilities are: he was an editor IAP Meghalaya, Secretary IAP Guwahati 2001-3, Secretary IAP Assam 2015, and is a member task force of Government of India on COVID-19 preparedness for children. So with this introduction, I hand over the mic to Professor Rashna Das Hazarika for her talk on meningococcal conjugate vaccine. Over to you, madam.
Thank you very much, sir, for the very kind introduction. I hope I'm audible.
Yes, madam.
And my slides are visible.
Yes.
Yes.
Yeah. So I thought I'll talk a little bit about the disease also, because whenever I speak about meningococcal vaccines, I still get a lot of questions and eyebrows raised on why do we need to even have this vaccine. And I was told by Nandini that maybe a little case presentation would be nice. So I'll try to finish. So my experience with this particular condition started in the Department of Pediatrics at Negrim, Shillong, where I was working at that time in March 2008. And this is where Shillong is, and you people are somewhere here, lower down. And it has these many districts. So the institute was here in a place called East Khasi Hills, which also houses the capital of the state. So this 9-month-old boy was brought in with fever and running nose for 2 days, sleepy and not feeding well since the morning. So it sounded like a typical, viral infection. But on examination, this baby had tachycardia, weak pulses with prolonged CFT, responding only to painful stimuli and a bulging anterior fontanelle. So correctly, a diagnosis of bacterial meningitis with shock was made, and the necessary treatment was started, and baby was shifted to the PICU. The CSF was hazy with 3,000 cells, 78% polys, high protein and low sugar, and the platelets were adequate on smeared, electrolytes were normal. With the treatment, the tachycardia and CFT normalized. By afternoon, we got a call from a microbiology colleague saying that she had seen gram-negative diplococci on the gram stain. And so we rushed to see what it was, and this is what she showed us. I don't know if you can appreciate it, but these are the tiny little spots here, which are the diplococci. So just on a little magnification, you can see, and this is what she showed us. And she said that this is serious and you need to be very careful. And in the late evening, we found that after the shock improved, this florid rash appeared. So based on the clinical features and the CSF gram stain, we got a confirmed diagnosis of meningococcal meningitis with meningococcemia. The child was isolated, contacts in the treating unit, health personnel was given chemoprophylaxis, and we did contact the state IDSP unit because this is a reportable disease. And while we were interacting with the officials from the IDSP Meghalaya state, they said that the first few cases were seen in a district of Meghalaya called Jaintia Hills, which is a coal mining district, in January 2008, where the medical officers had reported that they were seeing a lot of fever with some rash, and which was an abnormal observation, but they were not able to place it that this was meningococcal infection going on. And this particular case was the first bacteriological confirmed case, and a full investigation into the epidemic took place with a visit from the NCDC team, where they went visiting these areas and found these are some of the pictures which were shared by the NCDC team with us. All these kids were there in the villages with fever and rash. And gradually more and more cases started being reported. There was a state of panic in the public. The IDSP unit developed a reporting format. And here in the institute, we had collaboration with the microbiology department and on how to get a more microbiological yield. And a lot of discussions went on chemoprophylaxis and vaccination. So just to, this is how I'll go through it very quickly. To introduce, we know that this is a fastidious encapsulated aerobic gram-negative bacteria. The infection with Neisseria is meningitis is quite common, but majority are transient. So most of them probably we won't even know. We will think that we had a viral infection. But what is important is 10% of the healthy population survive as nasopharyngeal, they are nasopharyngeal carriers. And these carriers are important because they contribute to the continued circulation of the bacteria in the community, and in the proper conditions are responsible for the outbreaks. And the importance of this disease has increased after the introduction of the Haemophilus influenzae B vaccination, and meningitis due to that HIV becoming less and less. So this is a leading cause of bacterial meningitis worldwide, and there are two main forms of presentation. That is meningitis in 40 to 50% of the cases, and you're lucky if they get meningitis because they present early. The second is septicemia or meningococcemia in 20 to 30% of the cases, and the remaining are mixed infection. It is rapidly progressive, and therefore early recognition and diagnosis still remains a challenge. And it has a potential to cause epidemics with high mortality and morbidity. And as you can see, the estimated case fatality rate is very, very high. So what is the epidemiology in India, and why do we need to prevent through vaccination? Now, this condition can occur across all ages. And the infants are at the highest risk, followed by the second group, that is the adolescents, and the extremely elderly people who are immunocompromised because of their age. So practically it is seen mostly in infants, in the adolescents, in people who live in close groups like the military. Then we have the travelers to the endemic regions like the Hajj and Africa, and of course the health professionals. So globally, India actually is supposed to contribute a lot of cases, and this is what was found in 2018, where the contribution by India was very, very high. But in spite of this, we still do not have a policy of giving this vaccine universally. But many countries in the world with lower cases have included MCV routinely in the national immunization program. So this is in 2018. This is the case distribution all over the country. As you can see, nothing is spared. Even Tamil Nadu had 9 cases, 1 death. And West Bengal incidentally reports very high number of cases every year. And if you look at the national health profile and the NCDC data, you will see that from 2005 to 2022, this is the last data which is available. The 23 and 24 probably will come this year. There are still many cases, number of cases being reported and number of deaths. And most of these cases are due to serogroup A, B, C, Y, and W. In India, however, many epidemics have occurred periodically. So Delhi had many, many epidemics, 1966, 85, 2005, 8, and then Meghalaya had a lot of cases in 2008, followed by Tripura in 2009. And after that, hopefully we don't have, but still the disease is endemic in many regions in the country, and therefore there is a potential for outbreaks occurring anytime. Now, most common in India is the serogroup A. And as I said, some reports of CWY, and I think one case report of B is also there. Now, clinical presentation depends on where the bacteria has gone. So if it's a low bacteremia, just a mild flu-like illness. If it is invading the meninges, then it is meningitis. And if it goes to the bloodstream, it'll be a cytokine storm, so meningococcemia. So this is how you can classify the condition, because this classification helps you in initiating immediate and maximal intensive care support. And this is important because it can affect all organs in the body, and this can occur in a matter of hours. So these may or may not be associated with meningitis in all cases. So there are lots of challenges to this disease. And the first is the lack of awareness of the clinical presentation. As in the epidemic, it was observed only as unusual observation. In fact, this particular picture was sent to me from a medical college, asked if this patient was being treated as a drug rash. And the resident, the registrar who was there, had seen some cases with me and sent me this and said, man, can this be meningitis? This is purpura fulminans because of Neisseria meningitis. The rash, which is, we always associate it with the meningococcemia, and we think that the rash is mandatory. But when we analyzed our own data from that particular epidemic, we found that rash was present only in about 24% of the cases. So the cases can occur even without a rash. The second challenge is that it's a very smart bacteria with a lot of outer membrane protein, capsular polysaccharide, lipooligosaccharide, and there are porins and pili and opacity proteins. And what happens is that this bacteria can undergo antigenic and structural variation during infection. And this antigenic and structural variation helps the bacteria to attach to tissues, overcome tissue barriers, survive in the bloodstream, and penetrate the meninges. And then there is also an exchange of genetic material in the polysaccharide capsule. So it is seen that the switch of serogroup can occur in a particular region. And this has happened in Africa. Africa has a huge meningitis belt, and Serum Institute of India was helping by providing the Men-Afri-A vaccine, which was only for serogroup A. But then after that, they found that even after good control, they were started getting cases with other serogroup. So now the Serum Institute is now supplying a pentavalent vaccine to Africa and doing away with the single serogroup A vaccine. So therefore, it's a very smart bacteria. So the clinical presentation will depend on where the bacteria goes, and that decides the disease outcome. The CD alert, which comes from the NCDC, says that we always need to remain alert because it is seen practically in all parts of the country, endemic in most parts, and isolation rates are very, very low. So that is a third challenge. Why do we get low bacterial isolation rates? The reasons is that there are lots of obstacles in the microbiological diagnosis. The first being that it's a fastidious organism susceptible to cold, heat, and drying, and grows under these particular conditions. And therefore, it can die even before or during plating and result in negative cultures. Then you have, the economic constraints, lack of after-hours facility. PCR is very costly and unavailable to most of us. So therefore, many a times you get negative results, and we land up saying that this is not meningococcal infection. So the end result is underdiagnosis and underreporting. So how do we overcome? We need to have samples, whatever samples we can get, we should collect. We should transport it at room temperature. This is very, very important. Try to do a direct plating, right? Like when you're taking the CSF, maybe just put a drop on the culture plate, and try to take samples from all areas, blood, CSF, skin blisters, as well as skin scrapings. In our epidemic, we actually created a CO2-rich environment by using a Macintosh field jar, but later on we got the CO2 incubator, which helped us to get more cultures. The fourth challenge is the case management, because they progress very rapidly and can die within 24 hours. So sometimes we lose patients even before we diagnose. And it is very difficult to treat because they have multi-organ involvement. Sometimes we are happy when they come with meningitis because they reach the hospital early. So the prognosis depends on how fast the patient has come to the hospital and how fast you've given the first dose of antibiotic. So this is how it was in NHS. They said that even if you suspect, do not wait, give the first dose and then transfer the patient to the tertiary care center. The other challenge is that we are not reporting or recognizing, and therefore we are not, it is being overlooked by clinicians. So if you suspect a case, get in touch with your state infectious disease surveillance program, and you can start working with them so that you do not land up in a full-blown epidemic. So all these cases need to be reported, and this helps not only in controlling the epidemic, but also in serotype assessment. The sixth challenge is the antimicrobial resistance, because a lot of drugs are being used for chemoprophylaxis, and there is a lot of ciprofloxacin abuse in such cases. Quinolone abuse is already existing in veterinary science. And in my personal experience, when we were dealing with the epidemic, we found clinical ceftriaxone resistance occurring, and in the later half, we used chloramphenicol quite successfully. So these are some of the drugs that are used for chemoprophylaxis. As you can see, rifampicin, cipro, oflox, ceftriaxone, as well as azithromycin. And we found out that the best way for early and effective control of any epidemic of meningococcal infection is by mass vaccination. So this has changed, particularly when we talk of COVID-19. I mean, I think we have changed the way we look at vaccine preventable diseases. Now, what is important to understand is that the meningococcal outbreaks and diagnosis are uncertain, and vaccination is certain. Therefore, and we have vaccines which are available. So let us look at some of the vaccines which are there, because this is the most effective way in preventing this devastating condition. So there are, if you look at the pathogens age-wise, you'll see that barring for the early neonatal period, Neisseria causes infection in all age groups. And the meningitis in infants is, though the carriage rate is less, the first-time exposure actually may turn fatal. The same thing is also there in the elderly population. So what are the available meningococcal vaccines? Now, if you see, we have on one side ACWY, and the other is the non-capsular, the B. B is not very common in India, so I'm not going to talk about it. Initially, we had only the plain polysaccharide vaccines available. And in fact, in the beginning of that epidemic, our people had used the polysaccharide vaccine. And later on, we had the conjugate vaccines coming up, of which two were there. The Menafri A, which I've already talked about, and the quadrivalent ACWY. I don't need to tell you that the conjugate vaccines are always better for many reasons compared to the polysaccharide vaccines. And currently, we have only the conjugate vaccines available. of which these two are available in India. The Men ACWI CRM, which is from GSK, and the Men ACWI DT, which is from Sanofi. So this covers 4 serotypes, ACW 135 and Y. MNACWY is conjugated to CRM197 protein, and the Sanofi one is conjugated to the diphtheria toxin. The DT, MenACWI DT or Menactra was first licensed in the USA, and a lot of doses have been used in many countries. It has been used for more than 14 years, and the indicated age varies by country. So from 9 months to 55 years, and some give it from 2 to 55 years. It is WHO pre-qualified, and there is an FDA approval for a booster dose between 15 to 55 years of age. So in India also, a lot of multicentric studies have been done covering nearly all regions of the country. And they were done in 2 to 55 years of age, as well as below 9 months, from 9 months to 23 months. And they found out that if you look at here, the blue bar is for children from 2 to 11 years. The yellow is for adolescents, and the red or the dark orange is for the adults. So they found that there was a very good conversion for all the serotypes, AC, Y and W125, about 92 to 100% in achieving the protective titers. The seroprotection also against group A was good. And as you can see here, this data which shows that after the dose 2, 99.5% of the children achieved seroprotection across the 4 serogroups in India as well as in other countries. Then we come to the next vaccine, the MenACWI CRM or the MENVO. This also was found to be having a robust immunogenicity in the Indian population across all ages. So this, as you can see, there are 3 bars, and pre and post. For all the serogroups, the immune response has been very, very good. Then we have in the age stratified cohorts of children 2 to 5 and 6 to 10 years, there was a non-inferiority of the MenACWI CRM in comparison to the MenACWI DT for the proportion of subjects, but excepting for serogroup A, where they found the response was slightly less, and they could not, till now I don't understand why it has happened, but this is what the data suggest. So over 11 to 18 years also, it was very good, and it was non-inferior to the already existing MenACWI DT. So there was a good safety profile of both the vaccines, the ACWI CRM as well as the DT, and in all the age groups. And then they found out that if you use this vaccine with other vaccines, there was no problem, excepting for using the PCV13 with the MCV4. So if you need to give a 1-month gap for these 2 vaccines, otherwise you can give it at 9 months along with the MMR or the PCV or hepatitis A or even the hexavalent vaccine. So what is the real world effectiveness data? They have found that since the time of vaccination, the vaccine efficacy has been nearly 79%, ranging from 49 to 91% confidence interval below 1 year of age, about 69% from 1 to 3 years of age, and 61% from 3 to 8 years. So there is an evidence of overall effectiveness, the waning of the effectiveness of the vaccine over time, and therefore there is a recommendation and support for giving a booster dose in the adolescent period. This is a very nice study from Korea where they used the MENVO in the Korean armed forces, and they found that there was an 88.2% reduction in the incidence of invasive meningococcal disease in the armed forces after the vaccine was used with good safety profile. So if you compare both these vaccines, both are globally approved in many countries, and the long-term persistence, at least up to 5 years, is there in the age group of 2 to 10 as well as 11 to 18. They both are WHO pre-qualified. However, the difference in recommendation for age group is that the MenACWI CRM or MENVO from GSK is approved after 2 years of age. up to more than 70 years, and the men ACWY-DT or Menectra is approved from 9 months to 55 years of age. A word about meningococcal ACWY-X or the Men5 from Serum Institute of India, which has now replaced the Men-Afri-A. So this is not available in India. This is only for the African countries they're making. This is made for age group of 9 months to 85 years. And for these serogroups, including X, because there was a change in serogroup in the country. So this is again for intramuscular injection, 0.5 ml, diluted with 0.9% sodium chloride. So what about the scheduling and the global recommendation? Now, different countries have different vaccination schedule. Currently, there is no agreed consensus on a single optimal strategy. Nevertheless, all schedules in these countries have tried to address two things. One is a direct protection of the age group most affected by IMD, and second is to decrease the carriage and the transmission rates. So these are some of the countries, and there are more actually, which have taken up, but most of them have now gone for an infant plus toddler schedule. So try to protect these kids early in their life. For India, it is not included in the universal immunization program. We have the IAP-ACVIP right from 2021, which has come up with recommendations. And even now, the recommendation remains the same, that it is a reactive immunization towards outbreak and in high-risk groups. But some of the limitations are that if you give it an outbreak period, the outbreaks are short, abrupt and short-lived, and you may not have enough time to vaccinate the children because of immunological delay. And good number of cases, therefore, may occur even before the initiation of immunization. So this is how it is shown in our schedule as here meningococcal. If you are giving at 9 months, second dose at 12 months, and then later on you can continue to give up to 55 years of age. But this is a vaccine which is used in special situations. So it's in blue color. So what are the special situations? If there is a congenital acquired immunodeficiency, chronic conditions of the heart, lung, chronic systemic disease like kidney, hematological, hepatic, or diabetes mellitus, functional anatomic or hyposplenia or anatomic asplenia, cerebrospinal fluid leaks, and in use of cochlear implants. The other special situation is for international travelers. For Africa and Hajj, it is mandatory that you have to take the vaccine before going and visiting these countries, at least 2 weeks before travel. And students going abroad, it's a mandatory requirement from the universities that if you send your kid abroad, then they have to get this vaccination here. Laboratory personnel, it is definitely they should take it. And those people like pediatricians or intensivists working closely with these patients, it is good if they can take the vaccine. So first dose at 9 months for men ACWY-DT or Menectra, and second dose after 3 months. That is at 12 months of age. If you're giving above 2 years, a single dose, and you give 1 dose if you're going 11 years, followed by a second dose at 16 years. For the men ACWY-CRM or Menvio, it is indicated above 2 years of age. The booster dose is not very clear except in endemic areas and in high-risk groups where you can give a booster. For those with the special group situations, you will give 2 doses 8 to 12 weeks apart and a booster every 5 years. For asplenia, vaccinate at least 2 weeks prior to splenectomy and 2 doses 8 weeks apart. For HIV, it is 2 doses 2 weeks apart. For lab personal, single dose and repeat every 5 years. Now, the rationale for vaccinating early is because this is the group which is the most vulnerable, and you can, give it early for early protection. So it is projected to give about 85 to 87% at 9 months of age coverage and 95% at 12 to 15 months of age. Now, coming to my thoughts on vaccination, I think after you face an epidemic like that, I feel that this vaccine should be absolutely advocated for use in all endemic zones. India is endemic. Infants and young children, yes, and also in adolescents, particularly those adolescents who leave the house and they go to study outside. We have a lot of kids. I always say that a lot of our kids go from here to most of the places in the rest of the country. They may be carriers, and some people come from the rest of the country to our IITs and IIMs here. So I think they should be given the vaccine. The mass vaccination in epidemics is better because it gives immediate and long-term protection, as we have seen in the epidemic in Meghalaya. It also helps in nasopharyngeal clearance, and reduce the abuse of antimicrobials and prevent antimicrobial resistance. So with this, I'll end, and if there are any questions, I will take it up. Thank you very much.
Thank you, madam, for the wonderful presentation. And we will take on questions at the end of the SARS session. Now we move to the third session. Over to Dr. Kasi, sir.
Yeah. I'll just share my presentation. Screen is visible now, full?
Yes, sir.
Okay. So the last vaccine to be discussed today is the typhoid conjugate vaccine. I'm not going to discuss all vaccines. I'm going to discuss only the conjugate vaccine because that is the vaccines we are using today and that is what we need to know something more about. Well, like many other illnesses, India reports almost 58% of all global cases of typhoid fever. The age standard incidence rate is 411 per 100,000 and the age standardized death rate is 4.04, which is one of the highest in the world. Studies done in our country has shown high incidence of typhoid both in urban and rural areas, going as high as 1,622 per 100,000 in Chandigarh, but generally it is somewhere between 300 to 500. So there is no doubt that there is a definite need for vaccines against typhoid. Now, question, the highest incidence of typhoid is seen in which age group? Can we have some 5 to 9, 6 months to 4 years, 6 to 14 years, above 14 years? 5 seconds, we'll wait for the responses. So, let's see what is there. 6 to 14 to fine. Okay. Now, the correct answer is 5 to 9 years. Okay. If you look at why do we need to give the vaccine so early in life? If you look at the global scenario, taking Africa and South Asia as a whole, maximum number of cases are seen below the age of 1 year. If you look at data from our own country, the highest incidence is between 5 and 9. But what we must remember is there's a very high burden in the 6 months to 4 years. And that is the reason why the recommendation is to start using the vaccine as early as 6 months of life. We have basically two types of typhoid conjugate vaccines in our country. One is conjugated to tetanus toxoid and the other one is conjugated to CRM197. And all of them are spin-offs of these two. There's a lot of confusion about which is better. Is it tetanus toxoid? Is it CRM? Dispassionately looking at it, tetanus toxoid is chemically detoxified with formaldehyde, so your vaccine is going to have formaldehyde. CRM is naturally detoxified, so no nothing additional. Chemical detox can affect the surface epitopes available for conjugation. This does not occur with natural detoxification. Advantage of TTs has much higher number of T cell epitope binding site, with is less with CRM97. TT is supposed to have less binding sites compared to CRM, and the carrier induced epitope suppression is supposed to be more with TT rather than CRM. Let's not split hairs. There is no data as far as immunogenicity and efficacy to show that one is superior to the other. Now let's add a question. I put these two organisms over here. Both are rods, both are flagelli. So A is Salmonella typhi or B is Salmonella typhi. Let's have some responses, 5 seconds. Which is what? A large number are going for A. Okay, fine. Actually, it is B that is Salmonella typhi. If B is Salmonella typhi, what is A? Is it Salmonella paratyphi? Is it E. coli? Is it Citrobacter fruendi? What is this? 10 seconds. Well, I think common sense will tell us that it is Citrobacter fruendi. Why I have put up these two slides is to show that structurally and immunologically, S. typhi, the VI of S. typhi is indistinguishable from that of Citrobacter fruendi. There are clinical studies in non-human subjects to show that the clinical efficacy of C. fruendi is as good as Salmonella typhi, but none in humans. What we must remember is Salmonella typhi is a pathogen which requires biosafety level 3 for manufacture, whereas fruendi requires only BSL 1. So C. fruendi can be made in any vaccine manufacturing company, and that brings out the cost. And WHO has very clearly stated that whether you use Citrobacter fruendi or you use Salmonella typhi, you will not expect any changes in the immunogenicity or effectiveness. Now let's come to the clinical studies with TCV. Here I would like to specifically emphasize that I am going to talk only of clinical studies with TIBBA TCV because all other TCVs in India are licensed on basis of non-inferiority to the TIBBA TCV brand. All the others do not have this extensive data that is there with TIBBA TCV, so I will be concentrating only on this vaccine. This vaccine was studied in two groups, 6 months to 2 years and 2 to 45 years. The 6 months to 2 years was an open label trial. There was no comparator vaccine, whereas in the 2 to 45 years, the comparator vaccine was the polysaccharide vaccine made by the own company. This study was then extended with periodic publications till the end of 7 years. And it is important to know the antibody titers at each stage because that has lot of bearing on the recommendations which have been changing 2 dose to 1 dose, and will it become 2 dose again? So let's look at this. The first data available was at 1.5 years, 540 days. And if you see in the blue group, that is the 6 to 23 months open labeled group, there was a very, very significant decline in GMTs, whereas the decline was not so much in the 2 years to 45 years age group. Moreover, in this youngest age group, the seroconversion rates fell from 100 to 65%. This is data on file which was not published. So in 2014, when this vaccine was first recommended by ACVIP, because of these factors, the recommendation was use it at 9 months but give one booster at 2 years. Subsequently, we got the 5 years data, again not published but available in the background papers of the SAGE meeting prior to its recommendation in the 2018 position paper, which was published by the WHO. What they did is, at day 722 years, a cohort, sub-cohort was given a booster. They followed up the boosted and the non-boosted cohort till 5 years of age. Now, the hatched lines are all the boosted, the clear lines are the non-boosted. Let's concentrate only on the first and the third over here. You will notice that the titers and the GMTs in the 2 to 45 years old, yes, point estimates were lower, but they were not statistically significant. Okay. The same was also found in the 6 to 23 months age group. So boosted or no boosted, at the end of 5 years, the immunological response was almost similar. So in 2018, the WHO recommended a single dose of TCV from 6 months up to 45 years in typhoid endemic areas and said the need for boosters is not certain. The ACVIP also echoed the same and said that booster is not recommended in subsequent years according to available data. So it's keeping the question open. What is also important is the avidity index. See, avidity is the sum total of the attraction that an antigen has towards an antibody. Generally, an avidity index of more than 60 is taken as good. So let's take these two graphs. Let's forget the last one. In the non-boosted group at 5 years, there was a very significant fall in the avidity index, whereas once you boosted, the avidity index showed an upward trend, almost going to 54 to 52% had this high. Of course, this was not taken into consideration when the recommendation was made. Then came the 7 years data. Okay, so there was a follow-up till 7 years. Estimation was done by 3 methods. Vaccine method, where there is no established protective correlate of protection. For vaccine, we don't have a correlate. The Zoo-ELISA method, which has a protective threshold of 2 microgram for IgG antibodies. And this was the method that was also used in the Vietnamese trial. What we must remember is the reference sera for this method is now over. So we cannot estimate by now. Everyone uses the vaccine method. Now, with the vaccine method, the seroconversion and the GMTs with the booster was definitely far higher than in the non-boosted group. And that is why there was a lot of clamor for introducing a second dose of TCV. But we should remember that there is no correlate of protection. So when you do not have a correlate with this method, do we really need this high titers? Will this low titers do? What is the advantage of it? So when we applied the grade approach to ACVIP, we felt that there was no need for a second dose of typhoid conjugate vaccine. But in the 6 to 23 months age group, the same 7-year data was done with the Zoo-NIH method, the one which has a correlate of protection of 2 microgram per ml. And what did we find? Boosted or non-boosted, seroconversion rates remained the same. Boosted or non-boosted, the GMTs were almost similar. So this led to ACVIP not making any changes in the recommendation of one dose, which was done in 2018. Now, with the immunological data that I have presented, forget what ACVIP said. Do you feel the schedule should be 1 dose, 2 dose, 3 doses, or do we still not have adequate data? 5 minutes, 10 seconds. 2 dose, second dose, second dose. 4, I don't know. That's wonderful. 2. So I think the majority feel a 2-dose schedule is necessary, and I think the right answer is I don't know. Okay. Now why? Because the correlate of protection of 2 microgram per ml is not universally accepted. It was for a vaccine which had a different carrier protein, and that was extrapolated to the typhoid TT. We did not have any effectiveness data. We had the controlled human infection model done in Oxford, where it showed an efficacy of 87.1%. And then we had deduced the efficacy by means of what is known as the seroefficacy study, which again showed a vaccine efficacy of 85%. Subsequently, we have had extensive field efficacy studies, different age groups, different countries, of course, all typhoid endemic countries, where, sorry, very large cohorts and varying duration of protection. The Malawi study, 28,000 overall vaccine efficacy was 80.7%. When followed up till 2 years, the efficacy remained at 78.7, no waning. Bangladesh, the Tyvac study, 61,000. Vaccine efficacy, 85%. No significant difference in vaccine efficacy across the different age groups. Pakistan, over 200,000. This was done in the Sindh province, which had an outbreak of XDR typhoid. Vaccine efficacy was 95% against culture confirmed typhoid and 97% against the multi-drug typhoid. The Navi Mumbai pediatric TCV campaign done in Navi Mumbai. Vaccine efficacy 83.7. So everything is almost similar to the controlled human infection model and the seroefficacy study. Is TCV useful as an outbreak response vaccine? Sorry. We have another study from the outbreak in Karachi, where it was given as an outbreak response vaccine. The efficacy was 72%. Zimbabwe, the efficacy was 75 to 84%, depending upon what controls you used. Again, showing this vaccine is very useful as an outbreak response vaccine as well. How long will the protection last? We had the first study coming from Malawi with a median duration of 4.3 years. As you notice, there is a drop in efficacy between 1 and 5 years. This 90% of 5 years was because more of statistical issues. But this difference was not statistically significant. It showed that there was a 1.3% decline in vaccine efficacy 1 year, which is almost negligible. When it was stratified according to age, of course, the youngest age with point estimates, it was much lower in the lesser than 2 years versus above 5 years. But statistically, this difference was not significant. Then came the Bangladesh trial called the Typhoid trial. This was a very interesting trial. I just spoke about Tyvac. In the Tyvac trial, the control group had received JE vaccine. After 2 years of follow-up, this same JE vaccinated were given the typhoid conjugate vaccine, and both the groups were followed for another 2.5 years. So in those who received the vaccine first, we had the 5-year follow-up, which is called the previous TCV group. And those who received JCE, the Japanese encapsulated, and then the typhoid conjugate vaccine has called the recent TCV group. And they followed them up 2.5 years to see what has happened. And what did they find? That in the recent TCV group, the vaccine efficacy was 84% versus 5.5% at the end of study. And if you look at the year-wise vaccine efficacy, at the end of the 5th year, the efficacy had come down to 39% with negative confidence interval, literally indicating that this is not of any statistical significance. So beyond 4 years, there's practically no efficacy. If you look at the age efficacy according to the age groups, below 7 years, in the past TCV group, the efficacy had come down to 24% again with negative confidence. That indicating that in the youngest age group, the waning of immunity is the fastest. Even if you look at the antibody titers, see, this is the youngest age group, that is less than 2 years. What you will notice is the antibody titers fall across all age groups, but the fall is most rapid in those who have received the vaccine below the age of 2 years. There is now some suggestion coming in that yes, there may be a need for boosters sometime around 4 to 5 years after giving the primary dose. I think it is time now for a relook at the need for a second dose of typhoid vaccine. This vaccine has been found to be in large post-marketing trial of TCV, it has found to be very, very safe with very few side effects and absolutely no serious side effects which warranted discontinuation of the vaccine. Finally, we know that typhoid cannot be prevented by vaccine alone. You also require WASH. What is WASH? It is the method utilized for improving sanitation and hygiene. So they looked at 4 groups. Those who had received the JE vaccine but not given better WASH. And this was taken as the reference, 0. once they received the JE vaccine, this is a subgroup from the Tyvac study, which was done in Bangladesh. So when you give JE vaccine with better wash, what is better wash? Own water supply, own toilet, soap available for hand wash. So just better wash resulted in a 44% reduction in culture proven typhoid. Now, if you gave typhoid conjugate vaccine but no better wash, the reduction was 57%. But if you combine better wash and TCV, it was 74%. Very clearly indicating that it is not only TCV, you require better wash also to eliminate typhoid from the community. So, thank you very much for a very patient hearing. Pleasure to answer any questions. Thank you. Dr. Yeah.
Thank you, sir. Thank you very much for our wonderful presentation. We will take the chat box now. 1 minute. Dr. Kamala Kannan has asked, if the patient had first dose of hepatitis A vaccine with a particular brand and come for the second dose to a different pediatrician, can we interchange with different brands since all brands cannot be kept for all the vaccines?
I think it's a very common question. There is interchangeability data between Havrix and Avaxim. There is interchangeability data between Havrix and the Helium vaccine, that is TZ84. But there is no interchangeability data between Havrix or Hevaxim with the live attenuated vaccine. So, generally what you should do is try not to interchange. Almost all the brands of the inactivated vaccines are interchangeable, but there is no data for interchangeability between the inactivated and the live. But you must remember that if the patient is coming for a second dose and you do not have the inactivated vaccine or you do not know the brand, one dose of live attenuated itself is sufficient. So in essence, interchangeability is acceptable, is okay.
There is one more question to you, sir, Dr. Sugumar. Child received hepatitis A vaccine first dose at the age of 2. Now at the age of 6 years, come for the second. What do you do, sir?
General principle of vaccinology, once you give the first dose, memory cells are stimulated. Memory cells of the immune system do not forget like our human brain. Okay. So whatever the interval, you just give the second dose and complete the schedule. You do not have to restart again. The only exception for this rule is for a vaccine which is not available in our country, and that is the oral typhoid vaccine, where maintaining the intervals is very important. If the intervals are not maintained, then you have to restart the schedule. This is general for all vaccines.
It's one question to madam. Child received dose of Men C in UK. Now he has come to India for the second dose. What to do, ma'am?
So I think the question has arisen because in India we gave the vaccine from 9 months of age, and we don't have a single Men C vaccine. We have ACWY. So here you have a one-to-one discussion with the parents and give the men ACWY DT vaccine because studies have been done only from 9 months of age. That's why the recommendation is from 9 months. But studies elsewhere have been done for even as low as 2 months of age. So in UK, they're giving it based on those studies. So it is okay if they come to India, you can give the ACWY DT. No issues with that.
There is one more question, madam. The men vaccine available in India cover ACY and
Yeah.
W.
I think he's
Answered the question, yeah.
Sir, this is for you. If Biovac A was given IM, is it considered an invalid dose? If so, should it be repeated?
Okay, general principle of vaccinology states that live attenuated vaccines multiply disseminate all over the body, gives rise to multifocal activation of the immune system. Inactivated vaccines goes only to the regional lymph nodes, so very limited activation. So live vaccines, whether you give intramuscular or subcutaneous, is going to work equally well. Inactivated vaccines, if given subcutaneous, may not work very well. So in this particular situation, BioVac A is a live attenuated. Whatever you give route, it's going to work. There is no need to repeat the dose.
Professor PRC sir has asked, any specific reason why Serum Institute is not manufacturing MCV in India, madam?
Because there is no demand for the vaccine in India. The demand is there from Africa, so they're producing it only for Africa. And if we have the demand for it, then I think they will even give this vaccine for use in our country.
There is another question. Can Manectra be given at 10th month along with the MMR vaccine or needs to be an interval of 4 weeks? Dr.
No,
Revati has
you can give it
You can
together,
give.
no problem. There is no issue with it.
confirmed.
There was one question why there required to be a gap between PCV13 and Menectra. Now, this is specific only for Menectra, the Sanofi vaccine. They found that if you use both together concomitantly, then some of the Prevnars, the serotypes of pneumococcus was not giving good immunological response. So that's why they said that you give a gap of 1 month. First, you give the Prevnar 13 and then you give the Menectra. But if you want to give it together, then you can use the other brand, which is Menveo, but that is above 2 years of age.
Right.
Sir, Dr. Kamala Kannan has asked, is there any poor antibody response when the TCV is given at 9 months while still the baby may be breastfed?
TCV.
Conjugate.
Okay. Typhoid. Now, this was a doubt even by the WHO when before they made so they did a post hoc analysis of 6 to 11 months, 12 to 23 months, and compared that with the 5 to 45 years. When they looked at the antibody titers, there was no statistical significance irrespective of the age of administration. So, maternal antibodies are not going to play any role. The immune system maturity is probably sufficient as far as the typhoid conjugate vaccine is concerned. So there is no reduced immunity if you give it early. So recommendation is to give from 6 months.
Sir, given a choice of BioVac A and Haverex A, what will we prefer given that single dose has a benefit of lesser cost as it is a single dose?
Well, to put it very, very clearly, BioVac A also has sufficient data and we have long-term data from our own country. Even the WHO has accepted the BioVac A or the live attenuated vaccine as a single dose, though initially ACVAP had said 2 doses for various reasons, but now it's a clear 1-dose schedule. There is no doubt that cost-wise, it's going to be less than half the cost if you use the BioVac A. The only point says, one, it cannot be used in immunocompromised. The immune response is slightly slower, so in an outbreak situation, post-exposure prophylaxis, it may not work as well. And finally, I think much, much more robust data with Havrix as compared to BioVac A. So I think these are the main. It's an individual choice. Both, I think, will work equally well.
Sir, what about the food handlers and the sewage workers for having a mass vaccination with
Yes,
hepatitis A?
yes. I think this is absolutely necessary. They are the biggest source of contact. I think we all know the story of Typhoid Mary. So I think they are the highest risk group. So if you're going to have only selected vaccination, these are the groups who should definitely need the vaccine.
Yes, sir.
Remember, this vaccine has also been shown to reduce the fecal excretion also in a small subset.
Madam, how about this meningococcal vaccine is endorsed by IAP and ACIP, madam, 2021. They don't have the record majority the patient that the students travel to Western countries, they are demanding that. And is there one dose is sufficient, or you have to go for a dose? The record is not available.
Yes. See, if the child or the person is going to a foreign country, usually it's after 18 years of age. So there a single dose is enough for protection. There are some children now we are giving to some children, let's say at 9 months and a second dose at 12 months. And if they decide, say, after they become 18 years to go, then probably in this group, I will give a vaccine at 18 years again before they leave, because I've already shown you data where the immunity wanes off. So that would be the stand. There is, yeah.
Kasi sir, during an epidemic outbreaks, do you recommend mass vaccination, number one? And if at all the post prophylaxis window period, how long we can take, sir? Like typhoid, we always recommend, sir, after the infection. Like hepatitis A, what is your suggestion? The post prophylaxis window period.
Now, as far as Tibbar is concerned, I think we have robust data from Zimbabwe and Karachi that it works very well as an outbreak response vaccine. So definitely it can be used in outbreaks. That is one thing. Now, the second point you asked is about hepatitis A, right?
Yes,
Now,
sir.
hepatitis A basically has a long incubation period. So when you give the hepatitis A vaccine to someone who has been exposed and not immune, or even better, if he has taken the vaccine and his antibodies have disappeared, the time taken for the anamnestic reaction is about 7 days, which is much longer than the incubation period. That's the reason why hepatitis A vaccines work so well if you give it within 2 weeks of exposure.
Thank you, sir. Madam, is there any chances that is one doctor has asked, why cannot government administer meningococcal vaccine at least in known epidemic areas to prevent death? And I just wanted to know what is the coverage. Your region has shown West Bengal has most number of death and exposures. What is the coverage of as of now the meningococcal vaccines, madam, across India?
Not given by the government at all. I think the cost is an issue, data is an issue. Now, see, this data which is there is surprisingly from the national health profile. And many people would, doubt the data, whether it and how they're diagnosing meningococcal meningitis. Even I feel, but, that is something which is available to us. But in spite of that, the government has not taken up this vaccination on mass, as a mass UIP vaccine because of many reasons. One is I think we clinicians are responsible. We don't report cases. The more we report, the more we will build up the data, similar for mumps. And secondly, it's a costly vaccine. So I think when the government decides, even for the epidemic, you won't believe it, I fought for 1 year before finally they decided to listen to us and give that time it was the polysaccharide AC vaccine. That was just around, I think, 650 or 700 rupees. But even to give that vaccine, the government took 1 year because they were, not sure who is going to give the funds for it. Is it the state government or is it the central government? So there are many issues like this which come when the government has to decide in giving or including a vaccine in the UIP. I think more than me, Kasi sir is more experienced. I think IAP has also not been able to convince for some things. And at least now, at least they've introduced the pneumococcal vaccine, the rotavirus, and the cervical cancer vaccine. I think that's a big step. So that is the reason, because there are many things involved in mass vaccination.
Is there a variation of serotypes among the four? During the Hajj pilgrimage or in the industrial countries, are they isolated any specific strain, madam?
See, in the Hajj, they say you have to cover all the four because all four are known. In India, we have major only serotype A. But if you're going for Hajj or to Africa, it is better to get coverage for all four. There is one more question here in the chat box. Men B vaccine given in UK from 2 months, but it's not available here. So how to counsel the patients? The first thing is that you tell them that Men B is very, very rare in India. I think there is only one case report. So there is nothing to worry about it. And whenever they go back to their to UK, they can take back the other doses. So that's how I do in my practice.
Dr. Rashna, can I ask a question?
Yes, sir.
Now, the NHP portal has said 153 cases of meningococcal meningitis in Karnataka. When this was published, in fact, all HODs were contacted, and none of them remember seeing a meningococcal at least for the past 1 decade. So, the veracity of the NHP portal, I think, is something we need to look into. Second, we are giving vaccines at 9 months to 2 years. That is fine as an endemic country. During epidemics and outbreaks, which is more common in our country, there's a shift of age to a little older age group. In fact, young adolescents are also getting involved. So this protection is not going to last for that long. So are we creating a false sense of security by just giving childhood vaccines and really not talking about adolescent vaccines at all?
Yes.
And the other thing I corollary is, I know Northeast you have a lot of cases. South we have never seen. Believe me, I have been in practice for more than 40 years, and I've not had chance to see a single meningococcal in Bangalore where I have practiced. So, should we have, like JE, should we have declared districts where meningococcal is necessary, not necessary? Can ICVIP or IAP think along that lines? I think you need to give the guidance regarding that.
Yeah, the first question which you talked about, the NHP portal, I also agree with you. So we always take it with a pinch of salt. But all said and done, the NCDC now comes up with their data, and these are confirmed cases or probable cases. So if you want to confirm, you go back to NCDC website and see what their data is. Number one. Number two, about the adolescent age group, I fully agree with you that we are ignoring this group. And in case of the epidemics, we, in fact, I didn't show you the slide. In our epidemic, we had two age groups. One is below 5 years of age, and the other was in the adolescent age group, so 10 to 14 years. So these were the two age groups which were affected the most. So in case of epidemics, we know that it is the adolescent group which is going to be affected. So yes, we have to counsel, and probably the ACVIP can come up with a recommendation that in at least the adolescent group, this vaccine should be advised, because anyway, when they go to stay in hostels or they go outside, this is a vaccine which I feel it should be given because it prevents a deadly
Potentially fatal.
Yes, I remember Ashok Datta sir telling us about a girl who got on the flight from Delhi to go to UK. She got sick on the flight, and by the time she landed, she died. And this was a case of meningococcal infection. So this is so rapid. So I think in that age group, ACVIP can definitely come up with a recommendation that at least one dose should be given.
Right.
And
And
like
did I
like
miss any other questions, sir?
like PCV, we have plenty of strains coming up new, sir.
Yeah.
New, madam. So we have 13 serotypes in meningococcal vaccine. Is there any pipeline for coming a new strains later?
Yes, that is what has happened in Africa. So Africa, initially it was all serogroup A. But as soon as they started giving mass vaccination with the Men-Fre, there were other serogroups appearing, because the bacteria has the capacity to change its capsular antigen. So that's why the Men-5 has been introduced. So yes, once we use, now as of now, the quadrivalent vaccine is the one which will cover most of the infections. But later on, like in pneumococcal, we are saying that some strains can occur. We always have to look at the evolving epidemiological data.
Thank you, madam. Sir, there is one question I think you have answered. For food handlers, what is the vaccine schedule for TCV type?
Same, one single dose. That's
one
all.
single dose.
That's it.
Thank you, sir. So if there is no further questions, I will.
Sir, can I just, Kasi sir, I think
Yes.
the best way to go for the typhoid second dose is to give at 5 years of age, or maybe
Yep.
4.5 for
Yes.
longer coverage. What is
Yes.
your opinion?
Exactly, because the Bangladesh study has definitely shown the definite reduction in the 4th and 5th years. So the booster should be between 3 to 4 years after the primary dose. So that comes somewhere aligns with our 5 years booster.
So thank you, madam, and Professor Srinivas Kasi, sir.
I am not
Now-
professor.
Sir, you are emeritus, sir. I'm telling you are an emeritus now. Sir, Dr.
You are more
Srinivas
than
is
professor. You may be given honor professorship, Dr. Kasi.
Dr.
In-
Srinivasan, sir, any thoughts from you, wisdom from you?
No. My wisdom is very limited when compared to these people. So I enjoyed their thoroughly, and it's always wonderful. Both of them had done full justice in covering all the aspects. Thank you.
I can acknowledge the presence of Kesavalu, sir.
Yes.
Good evening.
Thank you for joining. Tirumurugan, are you there?
Yes, sir.
Hello? Yes, sir. I'll hand over
Yes, sir.
for further proceedings.
Yes, sir. Thank you very much, sir, for this wonderful opportunity to be here, actually, to listen to sir again, and to Dr. Hazarika. And I think we are a lot more enlightened, and hopefully we will take all this in our practice. Thank you very much. And we are really indebted to Dr.
Dr.
Kasi sir
Kasi,
for,
take care of your throat also.
I know.
yes, sir. So thank you very much, sir, and then hope to see you again in a couple of months' time. Thank you. Good night.
Thank you, sir. Thank you, madam. Thank you.
Good night, both.